Hi, welcome to Conversations in Interventional Cardiology. My name is Andy Goldsweig, and I'm an interventional cardiologist, University of Nebraska Medical Center in Omaha, and associate editor of the Journal of the Society for Cardiovascular Angiography and Interventions, JSCAI. I'm thrilled to represent JSCAI and our editor-in-chief, Dr. Alexandra Lansky. You can find us online at jscai.org, that's JSCAI.org, and follow us on Twitter at myjscai, at MYJSCAI. JSCAI is home to all official SCAI documents, and we're here today to discuss an important recent publication in JSCAI, the SCAI Clinical Practice Guideline for the Management of Patent Foramen Ovale Closure. I was honored to serve on the technical review and writing committees for this, so I know how much work went into this critically important document. Today, we have an esteemed panel of internationally renowned experts. Dr. Clifford Kavinsky from Rush University, chair of the SCAI PFO Guidelines panel, and Dr. Robert Sommer from Columbia University, director of invasive adult congenital heart disease there. To get started, Dr. Kavinsky, this document is the first US guideline on the management of patent foramen ovale and covers not only stroke indications in young people, but many other indications and many other populations as well. Could you summarize for us the guidelines, take our listeners through the new guidelines?
Well, thank you, Andrew. First of all, I'm very grateful for having the opportunity to serve as chair of this writing committee. And I am very thankful that SCAI is giving me the opportunity to do this. So I have prepared some slides to kind of go over this topic. And if you don't mind, I'm just going to try and bring those up. So as you can see here, this is the opening slide as the title, the SCAI guideline document. And here is the writing committee. This whole topic has spanned over 2 decades, and I think Bob Sommer knows better than anyone how much time and effort has gone into this the PFO space and the need to have a procedural-based method for closing PFOs. There have been several randomized controlled trials, and I'm not obviously going to go through all these trials, but suffice it to say that 4 of them were recently published in the last several years. And each of the 4 contemporary trials demonstrated a superiority of PFO device closure plus medical therapy over medical therapy alone in reducing recurrent ischemic stroke in patients who have had PFO-associated strokes. Based on the robust nature of these contemporary randomized controlled trials, the FDA proceeded to approve first 1 device, then 2 devices for closing PFOs in this patient population. So SCAI realizing that with the commercialization of PFO closure, that there were going to be many interventional cardiologists across the country who would be interested in taking up this procedure. Since SCAI is the voice of interventional medicine, it fell to them a responsibility to ensure the safe and efficacious rollout of this technology to the public. So there was a need in 2018 to ensure that the institutions who were carrying out PFO closure and that the implanters who were doing this procedure had the necessary cognitive and technical skill sets to perform this procedure safely and effectively. So this led to the formation of the initial writing group and a consensus statement, which was published in 2019, which I had the honor also to be involved in, which addressed the essential cognitive and technical skill sets required by not only the proceduralist, but also the institutional resources necessary for a successful program. And it also laid out that not only did you have to have a program, but there were important quality metrics that you have to monitor in order to have a safe and effective program. Now, this document most notably did not address the controversial issue of patient selection. Patient selection is one of the most important topics surrounding this space. And so this just addressed the institutional and operator requirements. So we knew when we published this document that there was a need for a follow-up document, was to provide guidelines for practitioners for proper patient selection, because patient selection is key to the essential procedure and one of the areas of greatest controversy. And this is partly to prevent unnecessary procedures from being performed. And it is important to achieve alignment of cardiology and stroke neurology around this. Because leading up to this point, cardiology and neurology opinions surrounding percutaneous PFO closure have at times been quite divergent. And then the important issue that needed to be addressed in addition was that many of the patients that we were interested in treating who had PFO-associated clinical events were not included in any of the randomized clinical trials. So some clarity had to be given to addressing these patient subsets as well. So we thought that this document could address the need for PFO-associated events that were not being addressed in the randomized trials. So we felt that this gave the opportunity to the SCAI to step out in front as a source for developing a guideline document. You know, thus far, the American College of Cardiology has largely led on most of the guideline documents. But when we enter into the interventional space, I think it's important for the SCAI to be the voice here, and there's no reason why they can't lead on these kinds of guideline documents. So this was hopefully going to be the first guideline document generated from the SCAI. And it is important, as I said, for this kind of stakeholder society to do this. And it was important to us as the SCAI to partner with neurology to assure alignment in these recommendations across all these disciplines. This is the front page of the paper. Now, our writing group consisted not only of interventional cardiologists who have who are stakeholders in the PFO space, but it also included representatives of the American College of Neurology. And there were methodologists who were part of this project, and I'll speak more to that in a moment. And interesting and important, we also included patient advocates, patient representatives, patients who have had PFO closure, and we felt that it was important for them to have a voice in this whole process. So for this guideline document, the first of its kind by the SCAI, we used the GRADE criteria, which is a standardized, rigorous, and recognized method for evidence collection, appraisal, and synthesis. As I said, we convened an SCAI panel of clinical experts in PFO closure. We had methodological experts and representatives of the American Academy of Neurology, as well as patient representatives. We used this panel to develop a series of important questions. Questions focused on areas of uncertainty. And each question was then subjected to very rigorous systematic evidence review. And then we had three 2-hour virtual consensus meetings where we discussed these things. And these clinical questions that were developed centered upon 4 areas: PFO closures in patients who had not had a prior stroke, patients with other stroke risk factors, patients requiring long-term anticoagulation for other reasons, and obviously what I had mentioned earlier, patient subsets who had not been studied in the randomized clinical trials. And through this, we developed a series of 5 clinical questions, 5 questions. And I'm listing the questions right here so you can see what they were. The first is percutaneous PFO closure versus medical therapy in patients who have not had a prior PFO-associated stroke. Now, this then includes many of the patient subsets who are not included in the randomized clinical trials, such as patients who have migraine disorders, patients with scuba divers with PFOs who have had prior decompression illness, patients with platypnea orthodeoxia, thrombophilia, patients who have high-risk morphologic anatomy, such as atrial septal aneurysms, and patients who have had systemic embolism, not stroke, or TIAs, or DVTs. These are important patient subsets that we see in our daily practice that there is no clarity on. Second question was PFO closure versus antiplatelet therapy in patients who have had a prior PFO-associated stroke. Now, this question aligned itself with many of the published randomized clinical trials, and this is the question for which there was more data support, as you'll see in a few minutes. And we focused on patients between the ages of 18 and 60, older patients, patients with atrial fibrillation, with thrombophilia, with high-risk anatomy. We talked about the use of the Rope score, and we talked about patients who have had prolonged periods of time since their index stroke. And then we addressed the issue of percutaneous closure versus anticoagulation in patients with prior PFO-associated stroke. Again, addressing the same patient subsets between 18 and 60, older, high-risk anatomic features, and prolonged periods of time since the index stroke. And then we addressed patients who, for PFO closure plus lifeline therapy anticoagulation versus anticoagulation alone in patients with prior PFO-associated stroke who require anticoagulation for other indications such as DVT, pulmonary embolisms, or thrombophilia. And then lastly, we try to address the issue of post-procedure management after PFO closure, addressing either 1 month of aspirin plus clopidogrel, followed by 5 months of aspirin versus another antiplatelet regimen or anticoagulation. So these were the 5 critical questions. And applying the GRADE protocol, we were able to give a recommendation to each of these questions in 2 phases, either the certainty of the evidence, either high, moderate, low, or very low, and the strength of the recommendation, either strong or conditional. Now, I'm not going to go through each of these lines, but the strength of the recommendation has different meaning to different people. If you're the patient, most patients would want the procedure for strong recommendations. If you're a clinician, most individuals would follow these recommendations, and so on down the line. So here is the specific recommendations based on the first clinical question that I had alluded to earlier. So this is the question that addresses other patients who have not had strokes, such as treatment with migraines. So you can see for the most part, based on the existing evidence, for migrainous disorders, for patients who have, for scuba divers who have had prior decompression illness, we do not, it was the opinion of the panel that routine closure of PFOs in these settings, based on the existing data, probably should not be done. In contrast that to patients with platypnea or orthodeoxia, even though the existing data is not strong, it was the opinion of the panel that these patients do have their PFOs addressed, since the results of PFO closure in these patients can be so compelling. Once again, in patients who have thrombophilia and without a prior stroke, you know, there is not a strong thrust to close PFOs in these patients. And this is similar for patients who have high-risk anatomy, such as atrial septal aneurysms. For patients with who have systemic embolism, but without a PFO-associated stroke, if other causes have been excluded, the panel suggested that PFO closure is better than medical therapy alone. And I think this is important to know. In patients with TIAs and no stroke, we do not recommend routine closure. And in patients with a DVT and no prior stroke, again, we do not recommend closure. So that summarizes the population of patients that many clinicians see who have a PFO, a syndrome, but no associated stroke. Now, the second question addresses the population that aligned itself most closely with the randomized clinical trials, and for which the data is the strongest, as you see in recommendation 2.1 in patients between 18 and 60 with a PFO-associated stroke. The recommendation is strong that these patients should have their PFO closed, combined with follow-up medical therapy. In patients over the age of 60, we once again recommended closure, although the strength of the recommendation isn't as strong. And in patients with a history of atrial fibrillation who have had a ischemic stroke, the panel advises against the routine use of PFO closure, but the strength of this recommendation is conditional and the end of evidence is very low. And this also applies to patients with thrombophilia and on antiplatelet and not anticoagulation who have had a prior PFO-associated stroke. These patients, the panel did suggest that PFO closure rather than antiplatelet therapy alone would be beneficial. So in patients with high-risk anatomy and patients with elevated rope score, they apply to the earlier recommendation. And then, the time since the index stroke is an area of a lot of discussion and controversy, and there is very little data to support this, so we recognize this as a knowledge gap. Going on to question 3, comparing PFO closure versus anticoagulation with a PFO-associated stroke. You can see in recommendation 3.1, the SCAI recommends PFO closure plus antiplatelet therapy rather than anticoagulation. And I think this is an important recommendation. And I believe this also applies to patients who are older than 60, that the same recommendation holds true. And patients with high-risk anatomy and based on rope score, they would apply to the same recommendations as 3.1 and 3.2. And then once again, we have a knowledge gap on the length of time since the index stroke. Moving on to, now this question surrounds patients who have other indications for chronic oral anticoagulation and whom have had a PFO-associated stroke. So this is an important population of patients. So you can see in patients with thrombophilia and prior PFO-associated stroke, we recommend PFO closure in addition to lifelong anticoagulation rather than anticoagulation alone. Now, why is that? We had a lot of discussion around this, and the reason surrounds the fact that even patients who take oral anticoagulation, there's a lot of data that suggests that noncompliance is a big issue, even if you're on a NOAC. And many of these patients require intermittent cessation of their anticoagulation for a variety of reasons. Doctors will discontinue anticoagulation for dental procedures and for all kinds of minor surgical procedures. When you have interruption of their anticoagulation, they are at theoretical risk. And I think this concept is at the underpinning of the recommendations for question 4. And this applies then to patients who have had a DVT and a PFO-associated stroke. The panel recommends PFO closure plus lifelong anticoagulation rather than anticoagulation alone for the same principles as outlined just a moment ago. And this would again apply to patients who have a history of pulmonary embolism. And then finally, post-procedure management of patients undergoing PFO closure. There is such a paucity of data surrounding this field, this area for post-procedure medical therapy for these patients. So the panel did not feel there was adequate data, nor could we reach a consensus regarding post-procedure medical therapy. So we felt that no recommendation could be made beyond 1 month of dual antiplatelet therapy after PFO closure. And I think this is a knowledge gap which has to be addressed with future research. So I know I've taken a bunch of minutes here, but in conclusion, these guidelines, the first, I would point out, the first published by the SCAI concerning an interventional procedure, will help clinicians and patients make decisions about the management of PFO, including transcatheter closure and its alternatives. It will help to inform policy, education, and advocacy to describe knowledge gaps, such as the duration of medical therapy after PFO closure. I think this will help to support interventional cardiologists and neurologists in confronting a broad spectrum of questions encountered in contemporary practice and for which none of the randomized controlled trials really address. And it will help patients and clinicians achieve the best evidence-based care consistent with the patient's values and preferences. So with that as a sort of a rapid introduction, I'll turn it back over to Andrew to lead the discussion.
Wonderful. Thank you so much, Dr. Kavinsky.
I know that was fast, but you know, there was a lot of stuff packed in there, and people will just have to read it over and read over the document for themselves.
We're very grateful to you and your panel for putting together this guideline document. This is great news for clinicians, for patients with PFO, and for interventional cardiology, and in particular for SCAI as a society. We should note that these guidelines were simultaneously published in JSCAI and presented in May at the SCAI scientific sessions in Atlanta. Now, let me turn toward Dr. Sommer here. This guideline, as Dr. Kavinsky says, is packed with information and really brings together a lot of data from a lot of different sources, data, honestly, of varying strength. So first question for you is, how will and should this guideline affect interventional cardiologists and neurologists' clinical practice? How should we change our practice in terms of interdisciplinary collaboration, patient selection, medical therapy, you name it?
So let me just start out by saying thank you to the writing group, because I think this is really an important document. Having been in this field like since the beginning, you know, we've gone through quite a lot to get to where we are today. And I think, you know, even still, this field is still in its infancy with respect to many of these indications that are discussed in the guidelines. Now, I think the audience needs to remember that, you know, there's only one approved indication for PFO closure. And so everything else other than prevention of recurrent PFO-related ischemic stroke is a consensus opinion from the panel. Now, that being said, they exhaustively researched the literature. They had representatives of interventional cardiology and neurology, as well as patient representatives. So I think, you know, the document in many ways represents our best opinion on many of these topics, even though we don't have the strong clinical trial data that we have for recurrent stroke. So yes, I think it's incredibly useful because not only is it going to help guide cardiologists and other clinicians in terms of choosing patients for this procedure, but I think it's also going to provide some serious guardrails against the indiscriminate use of this procedure, which you have to realize that we've now put, you know, FDA approved devices into the hands of interventional cardiologists. And I'm quite confident that off-label use will increase. And I think that's why it's so critical, not to go on too long, but I think it's so critical that collaboration is the foundation of patient selection here. You know, this is not just stroke neurologists anymore. We're talking about down the road, headache specialists. We're talking about pulmonologists who may be dealing with these patients who are hypoxemic. And there's going to be more discussions with hematologists. And so there's a wide array of doctors who are going to be involved and touching on these patients with PFOs. And it cannot be left to the discretion of the interventional cardiologist because, you know, because of conflict of interest, it's going to undermine the credibility of what we're trying to do scientifically and in the best interests of the patients.
You know, I think that's extraordinarily well said. It's important for us this document was important for us to lay out patients who should not be treated, just as much as it was important to us to lay out patients who should be treated, even though they may lie outside the FDA labeling.
I think you raise a lot of important points there. To kind of group them together, it sounds like this guideline document is really a starting point. And it's a starting point to tame the Wild West of PFO closure, in a matter of speaking. So let me ask, what do we need next? What research do we need? Or if you know, what research is underway to take this field to the next level?
I don't know, Bob, you want to take that?
Yeah,
I think
sure. I'll start with
you're
that.
involved with some of that.
Yeah, some of it. I think one of the really important suggestions or opinions from this piece was that there are certain conditions like orthodeoxyaplatipnia and other, very rare conditions which are related to PFO that no matter what we do, we will never have sufficient trial data to prove this. And so I think in some of those cases, when there's a clear mechanism implicating the PFO, and there are ways of testing that mechanism by, let's say, going into the cath lab and balloon occluding the PFO as a way to show that the patient's saturations improve. I think this is just a basic common sense type of approach to this. And the guidelines give some gravitas to that, kind of an approach. On the other hand, there are other issues like migraine, which I am very involved with. Migraine has been for 20 years a subject which we know is in some way related to the PFO, but the physiology and the mechanism linking the two is completely unknown still to this point. And so some early observational work by us and some others have led to the development of a national randomized clinical study called the RELIEF Clinical Study, which should be restarting again this late summer or early fall, which hopefully will address this issue. Because truthfully, with migraine, just like many other subjects in the PFO space, you don't want to be doing procedures on patients' hearts if you don't know that it's going to help them, right? And so patient selection is so critical in that space as well as many others.
And I think also the issue of, although smaller numbers, the decompression illness, I think there's a clear signal there, but lacks clinical data. And I would like to see more data come out from that area to sort of close the loop on that. And then the issue of post-procedure medical therapy. I don't know what's going to happen with that because, I don't feel there's a big drive to study that in a trial setting. And we reviewed the data. Andrew was involved intimately in reviewing that data. It's all over the place. So I don't know what's going to become of that. But I think the migraine issue is particularly important. I think the next 5 years, we'll see some clarity around that. The decompression illness, I think that's another place where we'll see some more data.
And I think, there were two areas which I think, I fit into this common sense approach to these problems without data, which are patients who fall outside the age range of the randomized trials.
Yeah.
I'll start with that one. Obviously, very few pediatric patients are going to get denied PFO closure in the setting of an ischemic stroke. I just don't think any insurance company has the heart even to do that. But in the patients over 60, there's still a lot of clinical resistance. And I think the point here is that the number of mechanisms for ischemic stroke are limited. And once we've ruled out with a thorough cryptogenic stroke evaluation by a neurologist, and I underscore it, by a neurologist, then I think that if there is no other source than the PFO, there's certainly no reason why these events in a 62 or a 67 or even a 75-year-old couldn't have been a paradoxical embolic mechanism. And I think once we've thoroughly reviewed that, then I think that's an approach that we can consider for closing the PFOs. But definitely, this is something that we could study, and I think we should.
And I think we will. Bob, just to dovetail off what you just said, I'm going to raise some hot button issues. One of them, as you say, with patient selection, is looking for ways to determine if the PFO is the most likely mechanism of ischemic stroke. Anatomic risk factors are something that has been the subject of research, but have not really panned out with certainty in the randomized control trials. And I think especially as you look at patients who are outside the 18 to 60-year-old ischemic stroke range, anatomic risk factors can be very important in trying to adjudicate who is likely to benefit from this therapy. The other issue, Cliff raised the issue of post-procedure antiplatelet therapy. And indeed, since we don't see a lot of short-term bleeding events in patients on 1 or 3 months of dual antiplatelet therapy, there's not a lot of impetus to study that. But what we do see occasionally is a signal related to very short-term, short-lived atrial fibrillation following these procedures. And I think that's going to be an important subject of research probably in the very near future.
So what do you think about that, Andrew? I mean, I've thought about this. We all see this periprocedural atrial fibrillation, which is a different entity than atrial fibrillation as an etiologic component of the index stroke. So I don't generally. Are you saying that the management of this is not standardized?
Well, in patients with ischemic stroke, I think it's very important to differentiate between short-lived periprocedural atrial fibrillation and potentially atrial fibrillation that may recur and may be etiology of a recurrent stroke someday. I can tell you my own personal practice is in patients who have atrial fibrillation associated with PFO closure, to put in a loop recorder and get 6 months of data to make sure that atrial fibrillation doesn't become a chronic problem. But we don't have data. I will be the first to admit that is a non-evidence-based approach.
I can speak to that just for a second. We just submitted a paper where we selected patients who had had loop recorders placed prior to PFO closure as part of a cryptogenic stroke workup. And we had 99 such patients. And what we found in monitoring the patients after their PFO closure, with a lot of caveats, this is not really pure data, this is retrospective data, this is one device data, there's a lot of caveats here, but nearly a third of the patients had transient atrial fibrillation. And so the question, I think that's something that we could study going forward, because all of our patients who had this transient atrial fibrillation, it peaked around 2 weeks after the procedure, and it ended by 8 to 10 weeks after the procedure, consistent with an inflammatory response to the device on the septum. And so, we felt very confident that we didn't need to treat these patients long-term, because we could see from the loop recorder that the atrial fibrillation was gone. But this is a huge issue in the stroke neurology population still. They're scared of this. Yes. And I think it's our obligation to prove that it's a different entity than the AFib they're seeing, because these patients don't have the diminished left atrial mechanics that most of the older atrial fibrillation patients have, which lead to the AFib in the first place.
I agree.
Very well said. Well, this is a very exciting topic, and I'm sure we could go on for quite a while. But just to bring it back home, I really want to thank Drs. Kavinsky and Sommer for joining us. We're thrilled to include this important document in the 3rd issue of JSCAI and to share this discussion with this incredible panel. Please follow JSCAI submit your own work to JSCAI. JSCAI is the official journal of SCAI, and you can find us at jscai.org and follow us on Twitter at @myjscai. Thank you both very much. Look forward to learning more.
Thank you, Andrew.